Welcome everyone. Thank you for joining us. Thank you for being here. We will go ahead and get started. So my name is Uju. I use they, them pronouns, and I'm one of the Health Justice Fellows at the Social Mission Alliance, and I will be your moderator for our conversation today titled Realizing Birth Justice in Healthcare and Health Professional Training. We are very excited to be here with a lovely group of speakers who I'll be sharing about their work in birth justice in just a couple of seconds. But we first wanted to start by sharing more about the convening body for this space, which is the Social Mission Alliance Student Assembly. So the Social Mission Alliance Student Assembly is a forum for health professional students interested in using their talents to advance health justice and social mission. They seek to do this by supporting the mobilization of health professional students and voicing their concerns, building community, exchanging ideas on how to advance equity in education, research, service, policy, and practice. So this is the second part of their ongoing webinar series for this semester, and you can learn more about them by visiting the Social Mission Alliance website. I will now be moving us to introductions of our speakers. So I'll start first with Tajah Hunter. So Tajah earned a Bachelor's of Science in Biomedical Sciences from Quinnipiac University in 2019 and a Master's of Public Health from Columbia University in 2021. She is a current third-year Public and Urban Policy PhD student at the New School. Her dissertation research focuses on medicine's role in the decimation of Black midwifery in the U.S. and seeks to explore the ongoing Black maternal morbidity and mortality crises' roots and historical traumas stemming from slavery and its vestiges. She is passionate about democratizing the birthing experience, as well as bringing community care and celebration back into it. So that's Tajah. Next, I'll be introducing Tajah Lewter, who is currently a third-year medical student at Howard University College of Medicine. Her passion is gaining experience to obtain her goal of becoming an advocating obstetrician, gynecologist, or pediatrician. Tajah currently participates in community service, research, and advocacy. While attending Howard, she has been an active member of the Advocacy Interest Group, also known as the AIG, and the Howard University Student Society of Obstetrician Gynecology. She holds advocacy positions in both organizations, and during her recent position as a community service chair for AIG, she's executed events to educate medical students on current healthcare policy. She's advocated on Capitol Hill by participating in the Student National Medical Association Advocacy Hill Day and the Medical Student Advocacy Conference. So that's a little bit more about Tajah. And I'll introduce now our last speaker, Sofia De Brito, who is a certified nurse midwife at Care New England Medical Group Division, Women and Infants Academic Midwifery at Brown University, OBGYN. Sofia completed her undergraduate degree in Latin American, Latino, and Caribbean Studies at Dartmouth College, and her graduate degree from Yale University School of Nursing. She has been in practice since 2017, and her clinical and academic interests include racial health disparities, anti-racism in medicine, LGBTQ+ healthcare, trauma-informed care, and perinatal mental health disorders. Outside of midwifery work, she enjoys traveling, seeing the world through her 4-year-old's eyes, and cozy bookstores, trying new foods, and dancing. All right, let's get social love, virtual applauses, snaps, reactions, emojis for our fabulous group of speakers tonight. Okay, so again, thank you all for being here. I hope you have a wonderful night. We will have our speakers speak on their work for the first part of the webinar, and then we'll have time for Q&A at the end. So if you have any questions, feel free to drop them in the chat box or hold them till when we hit our Q&A section. And I will now pass it to Sofia to ground us in some history around birth justice in the United States.
Hi, everyone. Good evening. I'm coming to you from Rhode Island, where I work in Providence, and I'm not a historian or a history teacher, but I did do a lot of research into midwifery and the history of midwifery and Black midwives here in this country. And what was revealed when I was deciding whether I wanted to continue the path in medical school or go down the less traveled route of midwifery was as you can tell by this talk and also by the racial historic past of the United States of America, it was strife with racism. And the reason why we have only about 10 to 12% of midwives doing births in the United States now in the 21st century is because of complete anti-Blackness and racism in this country. And so I'm going to give you a very, very long history truncated into a small amount of time. We only have 10 minutes to go over the history and ground ourselves in where we are today. But I wanted to start with what is birth justice? I don't know how many of you are in the perinatal care field or are striving to become workers in this field, but I wanted us all to have an equal understanding of what birth justice means. So it's a movement that aims to empower people during pregnancy, childbirth, and postpartum to reduce inequalities and suffering. It's part of the reproductive justice framework. So it's not a separate thing, but instead it is encompassed by the RJ framework and is based on the idea that birthing people have the right to make their own health decisions. So it was started and led by Black women and women of color and is driven by the long history of trauma and reproductive oppression that underserved groups have experienced, specifically in the United States. But birth justice is also a movement that is happening in other parts of the country, of the world as well. It recognizes inequalities in pregnancy and birthing experiences. It ensures birthing people can make decisions about their pregnancies, including seeking abortions, and provide access to culturally sensitive care, breastfeeding, body feeding support, and midwife and doula care. And it also aims to support marginalized communities during pregnancy and birth, limit unnecessary suffering, and reduce inequality, suffering, and needless death. As I hope everyone knows and understands, Black women in the United States die at disproportionate rates compared to white racialized women, 3 to 4 times. And in some counties, some states, some towns, some little areas in this country, it can be even higher than that. And it completely depends on where you live in terms of urban versus rural, and as well as hospital deserts or all of the labor and delivery units in this country that are being shut down because guess what? Birth doesn't make a lot of money and it's not part of the capitalistic structure. So let's talk about that. Let's talk about how we've gotten where we are with being a so-called developed country that has abysmal death rates for Black women and other people of color. And currently, the group that's rising up in those morbidity and mortality rates are the Latinx population, which has its own different non-monolithic ways and also language barriers, as well as the group that's hardly ever talked about because they've literally gone through a genocide in this country, the Native and Indigenous communities. Their numbers are so small that they sometimes don't reflect in statistics, but we can't forget that they too suffer from incredible, incredible rates of morbidity and mortality in this country. So if we can, I can take you back all the way to the 1400s to the 1860s. We can call this the, colonial and antebellum period, where childbirth was seen as a social event. You got pregnant and you were taking care of your community where you lived. A midwife would be there, usually a lay midwife with not a lot of what we think of now as professional education or professional training. And these people could be an elder in the community, a sister, a friend, but essentially this was social childbirth. And with the ways in which this country utilized slavery and enslaved people to build this capitalistic way that we live, grand midwives, which is a term that is used or now, but these midwives used to be called granny midwives, if anyone has heard that term. They started to come about as West African enslaved people were brought to this country and had knowledge and previous history of using herbs and herbalism to treat a lot of the concerns that were happening in a pregnant person. So this is what we were doing here until about the 1880s, after the Civil War, and about the 1900s, where there was suddenly a concern about the babies and how babies were dying. And around the time of, automation and industrial revolution, and understanding machine work and people having more, I guess, leisurely time to think about these things, and also making money off of people. The wealthier folks aim to, quote unquote, save the babies. And the US Children's Bureau was established in 1912, which started saving the babies, but particularly one type of baby, which is the white racialized baby. And this continued on into the 1920s with the Shepherd-Towner Maternity and Infancy Protection Act, or the STA, where they started instituting maternal and infant health programs, and they started requiring midwives to be licensed and trained by nurses. So a little pause right here in this timeline. In the 1860s up into the 1900s, about 80% of births were done in the home. That's the statistic that we have, and we think it's more. So they were done by midwives in your community, and it's called community birth, and hospitals were hardly utilized. And around the turn of the century, of the 20th century, as we started seeing the medical profession becoming more professional and actually having antibiotics and other technological advances, and the profession of medicine and doctors becoming people who actually could treat things instead of what we were used to, which were snake oil salesmen, or the other many fads that doctors used to go around telling folks about. So in this whole timeline, midwives started having a lot of requirements put onto them. And in the 1940s, the Hill-Burton Act was created, and it provided funds to build hospitals and health clinics for the underserved, but in separate but equal facilities. So think about the Grady hospital in Atlanta. And then we keep going, and we keep having these constant policies being made, right? So white women started becoming disenchanted in the 1940s and 1950s with the medical model of managing birth. And in this period of time as well, we see the American Medical Association completely annihilate midwives through smear campaigns, public campaigns, calling them unhygienic, dirty, low class. Only people in the low class could use them, that they didn't know about technology of birth. They didn't understand that birth was a dangerous thing for women to go through. But then at the same time, there was this counterculture of folks wanting to manage birth with the Lamaze method or natural childbirth. So we sort of see this resurgence of midwifery in the 1960s and 1970s, but mostly for white midwives. And we start seeing the American College of Nurse Midwives come about and creating even more strict requirements for midwives. So testing that was difficult for lay midwives to complete, especially if you were someone who wasn't going to school because you couldn't, because of racial policies or laws that weren't allowing you to access midwifery school, or the other thing, or to become a nurse, because again, midwifery in the United States is connected to nursing. And so there were a lot of new white midwives that came about in the 1970s and 1980s. And we began to revise licensure laws and sort of or undo the smear campaigns that the AMA had put against midwives for almost more than half of the 20th century. And in the 1990s to now, we now see a resurgence of midwifery, or at least us coming back into the fold. And we're not back to 80% of midwives doing births anymore, but we're sort of climbing up from 10 years ago only being 5% to now being 12%, but we still have a long way to go. And in terms of diversity in the midwifery workforce, that still has a long way to go too. We're about 95% white workforce, 5%, sometimes they give us a little bit more, like 92%, and say that about 5% of us are Black midwives. Then there are a little small percentage of Latinx midwives and Indigenous and others, or Asian. So there's a long way to go to diversify and bring back Black midwives, or grand midwives from what we were called in the past. But it was a long way of taking us little by little out of the system, and we're trying to get back in, but also create our own system, because the system that is current now does not allow for midwives to do what we need to do and create community birth spaces. That's really quick 10-minute intro to that.
Thank you so much, Ana Sofia, for that history and sharing overview of where we have been and where we're at now with midwifery and birth justice in the U.S. I'm going to pass it now to Tajah and Tajah to talk about their work integrating birth justice into health professions training.
Thanks, Uju. I'll discuss a project that Tajah and I worked on, and then we'll go a little bit into how some of the work in our everyday lives has continued since this project. So last winter, I was taking a class as part of my PhD program, and I was tasked with, by the end of the semester, to put on a workshop about an issue we cared about. So for some people, that may have been mental health or gentrification. For me, it was, my idea was to convene a group of Black women to educate them about the history and the continued importance of Black midwives. So as I know that Tajah is also interested in issues around birth justice, I reached out to her for help. And then along the way, we ended up meeting our friend Juliet, who's a nursing midwifery student. And together we convened a group of Black women, medical and nursing midwifery students. So we sought not only to educate this group about how essential it is that Black midwives be part of this conversation that's going on nationally about solutions to end the Black maternal health crisis and obstetric racism. But we also wanted to encourage community among these Black women that are going to be our future physicians and nursing midwives. So they were able to connect on the barriers they each face in their careers. All of them we found were there for the same reasons in their careers. They decided on this on their careers because of things they were hearing in the news about Black maternal health, but also things that happened to them personally or to their families while they were giving birth. And so also the barriers and experiences they had around racism at their institutions. And again, so this birthing justice issue wasn't just an interest for them, but it really hit home. So several of the medical students also in this convening learned for the first time that about midwives' roles on the birthing team. And the medical students also discussed how they could be better advocates for midwives. So I'm going to turn it over to Tajah to discuss some more about the takeaway from this workshop.
Thank you, Tajah. So I think the most important part about that workshop was that we learned about co-learning, and we learned about what we do. So I know that at Howard University College of Medicine, when we go into the hospital, we actually have midwives there. And I've heard a lot from like older classmates or just peers that are ahead of us, how much they actually learn from the midwives, and how like it's a collaboration. So I think that was actually the most important part. Sometimes people can get confused as to what a doctor does versus what a midwife does. And then also you just have to realize, like in the medical field, it can become a respect thing as well. Like people like titles and different forces like that. So we think that it's just very important to learn the separate entities, but also they're separate, but you need to collaborate in order to maximize patient-centered care. So I think that that was the most important takeaway from our workshop. So that's what we're looking to do further. We want to continue to do these workshops if we can, if we're fortunate, if we continue to make the connections just across the country with medical students, because not every institution is like Howard and has the midwives integrated into maternal health care. So I'm not really much of a talker, so thank you.
Yeah, and so building on what Tajah said, we also hope to build support for co-learning between these students, strengthen the support network between them to advocate for courses about perinatal racial health inequities, the history of grand midwives, hoping to encourage the creation of partnerships between medical schools and nursing midwifery schools with local birth centers and community-based organizations that support birthing people. And also encourage the establishment of student groups that allow Black midwifery and medical students to connect with and support one another. So now we'll quickly discuss some things that have developed since what have we been doing since this project? So I'm here for representing the work that I do as part of my PhD program, but I'm also an AMA staff member. And so I was lucky to work on a report that we did and really wanted to advocate that midwives and doulas be included in this report and in the conversation, again, for talking about the solution. So the study was a collaboration between AMA and Sinai Urban Health Institute, and it examined variations in access to maternal health care and infant health outcomes across Chicago neighborhoods. And so the main takeaway from that was low maternal care access, the closure of OBGYN units, and rates of inadequate prenatal care were all events that were concentrated in areas of the city that were home to majority Black residents, such as Chicago's South Side neighborhood. And another thing I'll highlight that I've been doing since that I'll perhaps talk about later that I implore all of you to do is just see what's going on in your own communities. So I've been working with my county's Office of Minority Health and was surprised to see all that they're doing on this issue, such as putting on baby showers for birthing people in the county. They have a Black maternal mortality morbidity task group. And they have regular meetings. And these meetings are among legislative, hospital, community leaderships that are open to the public. They educate the community members about midwives, and there's currently an unmet gap in my county as well as nationally, where Black women that want to use midwives, there's a gap there. So we're trying to see what that's about and how to close this gap. So I've been working with them for the last few months, and will continue doing so for my dissertation research. So I'll turn our last few minutes over to Tajah.
I don't really have much to say. Again, I'm not a big talker, so thank you.
Thank you both. I'm going to pass it to Ana Sofia to talk about the curriculum she's developed and implemented around supporting healthcare workers.
First, I just wanted to say kudos to Tajah and Tajah for doing the work that you all are doing, because I guess I came from a very privileged space where we had interprofessional longitudinal clinical care from the beginning at Yale School of Nursing. So that means that medical students, physician assistants, and midwives and nurse practitioners started together from their first year and did clinical care work throughout all of their years in a group where they got to learn about each other's role and practice and understand, and then go off into the real world, quote unquote, and already knew how to collaborate interprofessionally. So I wish that for more medical schools and nursing schools throughout the country and physician assistant schools, because that solidify what I knew about how we can all work together to get better health outcomes. And I currently am at Brown University, and we have a 30+ year academic midwifery service that actually teaches the medical students and residents of Brown's Medical School and their OB-GYN residency. So when you come to be a doctor with us, you get taught by us for the first 2 years on how to deliver babies and the midwifery philosophy of care, which is vastly different than the medicalized version that you get in medical school. And although we bump heads and we're constantly struggling to find a common ground, because the midwifery way is, radically different. You definitely have to buy into it and understand normal physiologic birth and sit on your hands so that you don't intervene and cause the cascade of interventions that can lead to morbidity, like a primary C-section. So kudos to you all for getting that done. And in terms of my work that I'm doing at Women and Infants Hospital, which is a hospital that does about 9,000 births a year for Rhode Island and southeastern Massachusetts. We're a small state. You can get through the state of Rhode Island in 45 minutes. We have 5 birthing hospitals. Women and Infants is tertiary care. It's the only one that has NICU, so everyone gets funneled to us. And the other hospitals also have midwives, except for one called Kent Hospital. But my work was about how can we get this reproductive justice framework into the hospital so that people have this framework to work from the beginning that they step foot into their new role as a nurse, as a provider, whether a nurse practitioner, midwife, or a doctor. And so me and my friends, because I always bring my friends along, but 2 residents and a second-year medical student who is now a 4th year and about to go into family medicine, so proud of her, created this project called Centering Reproductive Justice, a multidisciplinary training curriculum on reflexive anti-racism. What a mouthful, but essentially I wanted to use the word centering because in midwifery, we have this group prenatal innovative model of care for prenatal care called Centering Pregnancy. And I don't know how many of you have heard about this, but essentially you take about 8 to 10 or 12 women who are birthing people who are pregnant at all around the same time, and they come together for 2-hour sessions, and they sit in a circle and the providers facilitate the discussion. We don't tell them what to think, we don't tell them what to do, but instead we empower them to educate themselves and each other, down to taking their own vital signs, to understanding their bodies and their childbirth education and preparing for birth and postpartum and beyond. So I took that concept and put it into this, so that you take small groups of employees, anyone who interfaces with patients, and have them be in a group where they can actually have discussions. Because I don't believe, and research shows, that these 1-hour workshops on anti-racism or DEI workshops actually work. And there isn't even enough research to showcase that these workshops do anything besides make people feel like they're being scolded or don't have the opportunity to discuss their racism like encounters, or what it does is actually puts the burden on Black folks and other people of color to trauma dump or talk about their experiences for white people to hear, as opposed to putting the burden of talking about racism on the folks who are making the racist comments or making racialized work environments. And so the part about the reflexive anti-racism is the ability to come together week after week to sort of build upon what you learned the week before and talk with your classmates per se, or your group mates. You have pre-work that you do before you come to the session so that we all have the same language and understanding of what is going to be talked about. And these sessions are, we just added a new one, but they used to be 4 sessions, but they're now 5, with the 6th session on just a reflection of your experience throughout the time. So you can either in your institution make this every week or every other week. For the first cohort, we had it every other week just because it worked better for those folks. And I think that it gave them a lot more time to think about it and talk with their family members about what they're learning. And it created a really rich discussion when they came back. And the first session is power, privilege, and identity. You always got to start there. You always got to start with positionality and understanding where you fit into this world and what privileges you hold at this moment and what privileges you used to hold and what you don't hold. So everyone understands where we're coming. And we start with a very simple exercise about your name and what identities you hold. So a lot of folks realized early on in the group that the Black people always said, I am a Black person, and the white folks never ever mentioned race as part of their identity. So that is always a fun conversation to have. And then we have community-based facilitators come in and be part of it, and they get paid to be part of this project. So they get about $250 an hour. And our first community facilitator is actually a friend of mine from high school, because I bring my friends everywhere. And she is the DEI, the head DEI person at Brown's Public Health School. So she, she got her chops. And so she comes in and does a case-based study about a African-American male who has sickle cell disorder and how we talk about patients like this. So she presents a case that is written inappropriately by a doctor. And then we talk about how we can change the words that we use in that written HPI or history. I don't know if everyone knows what HPI is, but the history and physical and information that you receive from the subjective part of what the patient states. And then we rewrite it in a way that takes away bias, takes away the next person who's going to take care of this patient, understanding of who this person is without even talking to them, right? And then our second one is we bring in the director of Sister Fire here in Rhode Island. Sister Fire is a grassroots organization that is made up of women and binary folks of color, and specifically Black women who work on the reproductive justice. So she comes in to introduce the people to reproductive justice framework and essentially gives them a timeline of all of the reproductive injustices that have happened in the United States, and really truly like a historical and grounding informational session about that. And then we talk about how we've been impacted by reproductive injustices as well as even the men in the group too. And then our third and fourth are essentially based on different populations, third, fourth, and fifth. So the third one we do about Black maternal health, and we bring in a community-based doula. The fourth one we do on trans and non-binary care. It's very hard to be a trans person and come into Women and Infants Hospital and get your care there. And so we try to address that as well, and how to make spaces safer for folks. And we bring in one of our lead doctors who provides gender affirming care in Rhode Island to talk about that, and present another case about a pregnant trans person and how they lost their baby because of biases and because of people not understanding how to treat folks. And then our fifth one that we just put on is we have a community-based doula collective called Doulas Conectadas, which is a Spanish-speaking community-based doula group. And they come in and talk about our immigrant population, our Spanish speaking population, the language barriers, how doulas can come in and work on that as well. And then again, the last one being the reflective session where we come together and we talk about how this experience was and what are the next steps we're going to do as anti-racism champions now that we've gone through the course in our selective departments, because any employee can be part of this curriculum training. And so the findings that we've had in the past two iterations of it is that, well, I'll just leave you with one thing that one participant said was, everyone should go through this course because this course will save lives. And people stated that it was the first time that they were allowed to just really talk in depth without feeling judged about race and how race has impacted their lives. And I'm saying this from a white person stating that, meaning that they have never been allowed to talk about race in a way that they could ask questions and reflect upon their experience as a racialized white person and what they've done to people of color or Black folks as well, and their ancestry and other things, and come to terms with that. One thing I will say about this course is I make very clear that we are not here to coddle white tears, and that this is not that place for that. And if you feel like that, then I want you to sit with that and kind of journal on the side about why you're feeling that way, and come back to those thoughts that you're having and be able to share that without putting the burden on the people of color in the group of having to console folks. And that had to be reiterated always in our community guidelines every time we started our sessions. And so next steps for this is we're hoping to integrate this into nursing orientation. So every nurse that gets hired by this group, because that's what the community birth justice demands are asking of us. In Rhode Island, there's a whole document about what they want Women and Infants Hospital to do. And also trying to see if we can get the residents to go through it, the doctors to go through it, everyone who steps foot and interacts with patients to go through it. But it is a big ask on Care New England, and they don't see it as a priority because it does come with the budget. It does require paying community-based folks to come in and share their stories, their lived experiences, and their work with us. And that's where we're at right now, really fighting for this to be incorporated into every orientation schedule that there is. And you can do it too at your institution.
Yes, thank you so much, Anna Sophia. And thank you to Tajah, all of our speakers. Just hearing like the very diverse creative ways you all are organizing and shifting where you're at, the practices, the training, the policies, it's so great to hear. And I welcome people, if there's an idea that's percolating in your brain, or a quote or something that was said that really resonates with you, or a question, like drop in the chat, like let's conversation and engage. But yeah, thank you all so much for sharing more about your work. We are going to move now into a Q&A section. And so we do, in the registration form, there was a question around questions you have for the speakers. We'll start there. But if you have additional questions, I welcome you to put them in the chat box, and we'll ask them out loud to our speakers. So I'll start with the first question that we have from the registration form, which is, what role do communities, particularly those historically served by grand midwives, play in advancing birth justice? And how can healthcare professionals better engage with these communities? I'm also going to drop in the chat for everyone to see. So I'll open up to our speakers.
I can start with this. So I wish I could show you all the map of where grand midwives used to be in grand numbers, but I think you can imagine. Think about where slavery happened most, and those are the states you're going to think of in your head. Not to say that the North didn't have grand midwives too, but they did, and they also had other immigrant communities that were coming to the North of America that were also met with the same vitriol and hatred from the burgeoning profession of doctors, sort of in xenophobic ways. And if you think about those states, and now sort of juxtapose another map on top of that map in your head of where the most like statistical mortality, or where Black women are dying the most, they sort of match, right? So if you're thinking Mississippi, you got it. If you're thinking Louisiana also, and Georgia, and all of those states there coming up into the Northeast corridor, unfortunately, it really matches where there used to be 80% of home births happening and grand midwives proliferating and being public health servants. Really, that's what they were doing. That's what they were doing in their community. Now that there aren't as many midwives, and on top of that, we're having these hospital deserts where labor and delivery units are being shut down left and right. And then on top of that, we have these terrible policies that don't allow midwives to even function in their full scope capacity. So for example, I have a friend named Stephanie who's starting Birth Sanctuary in Alabama. And she is a certified nurse midwife who started in Boston, worked with me in Rhode Island, and then decided, you know what, I really need to go back to the South and open up a birth center for Black women in the South, where they have to drive 2 hours to get to the nearest hospital. And as a certified nurse midwife in Rhode Island, I have full independent practice authority, meaning I have hospital privileges. I can open up my own clinic. I can do many things all by my lonesome self. And I don't need supervision from a doctor. I don't need a collaborative agreement. I don't need any of that. Unfortunately, in Alabama, you need all of that and more. And to open up a birth center in Alabama, you cannot do that as a certified nurse midwife. You have to become a certified professional midwife, which you're wondering, what are all these words and acronyms? Well, because of the way that midwifery was completely disjointed in this country and tied to nursing, there have been multiple different pathways that you can get to midwifery. You can be a lay midwife, which means you're not licensed and you're technically practicing illegally. You can be a certified midwife, which is only allowed in 9 states. You could be a certified professional midwife, which is allowed in about 32 states right now. And those are the ones most people associate with home birth. And you can be a certified nurse midwife, which is allowed in all 50 states and territories of the United States. And we have prescriptive authority. And we can do abortions in a lot of the states in America and other full scope obstetrical care. And so unfortunately for her, she has been trying so hard to get this birth center sanctuary open, and now has about like 3 different degrees just to do this. And she, sued the state and the Department of Health of Alabama for impeding her from opening up this birth center because of all of the morbidity and mortality. And as you all know, Alabama also had their IVF law and policy and crazy reproductive injustices happening there. And so in terms of what you can do in these communities is where grand midwives were, or any community in the United States, I really think that you all should look at the laws that are governing midwives and petition or reach out to your local American College of Nurse Midwives chapter. Every state has one, and see if you can join forces to try and revise these laws and make it so that most states allow for full scope practice for midwives, so that we can truly practice in what we're good at.
I'd also add, from my perspective on this question is midwives are essential in community care. As Black folks, we know and have long known that no one's coming to save us. So with all of these bans that we see happening across the country, and even when the Roe v. Wade ban occurred, there were already networks of Black women, Black folks throughout states like Missouri and through the South that they already lived in states that had these bans. So, when that ban happened, they were basically like, we're going to continue our work because that's what we've always had to do. And so midwives have served this gap on the plantation. They've served it during Jim Crow when Black folks didn't have access to these hospitals. So, and they're here today as well, although of course there's many unjust barriers, as Anna Sophia talked about, but they're here today to continue to fill this gap.
Thank you both. And I'm looking at the chat. We have a couple of new questions and some comments. I'm going to read a lot of comments in light of the last question. The first is, I'm currently a nurse and nursing and track to be a woman health NP nurse midwife. I'm currently a birth doula. I'm from Boston. I'm afraid of the limitations of I would if I didn't stay in the Northeast. And then we had Tiara. Hey, Tiara. Lay midwives are not illegal in all states and also are called traditional midwives. So I just wanted to point out those comments before to see if there are any responses before going to the next question. But yeah, people are active in the chat. Love it. Well, I'll take us to our next question, and if any of the speakers have thoughts to those comments, or welcome you to share. But the next question we had from our registration was, has research shown a difference in using doulas for pregnant people of color? That's the question. I'll post it in the chat.
Happy to take this one on as well. So I'll answer it a little different. So more so, how's research shown a difference in using doulas and midwives as opposed to just a standard physician attended birth. So midwives and doulas have, research has shown that the use of them leads to higher rates of, or is associated with higher rates of breastfeeding, spontaneous vaginal delivery, and vaginal birth after C-section, in addition to lower rates of C-sections, preterm birth, low-weight infants, neonatal death. And research also showed that community support persons such as midwives, doulas, and birthing the partners of birthing people with no hospital affiliation were shown to mitigate acts of obstetric racism during hospitalization for labor, birth, and immediate postpartum care. And then another data point here is that compared to those cared for by physicians in hospitals, those that receive midwifery services in community settings experience higher autonomy and respect, as well as lower odds of mistreatment.
Yes. and I know it's doulas have done such a great job in this country of elevating their role in maternal health care, and they are being, to me, in my personal humble opinion, are being used as the band-aid solution for the Black maternal health crisis. And I love doulas. I love working with doulas. I love the work that has been done to elevate their role. But I fear that if we continue to put them on a pedestal and when they don't work to solve the crisis, because they're not going to, that's just unfathomable to think that only one group can solve the whole issues that we've been having for 100 plus years. It's going to set them back extensively. And so I'm all for increasing the number of doulas in the country, increasing the number of midwives, but we have to think about how we're doing that, because the offside of this is that it can become another cog in the capitalistic wheel of increasing the workforce and giving money for doulas to have a livable life, obviously, but then putting the same burdens and expectations of them that current midwives are suffering from being in the healthcare or the medical industrial complex system as well. Midwives currently work mostly in hospitals instead of community birth settings because of the way that we've been set up to only have those spaces to work in, and home birth not being an option everywhere, and birth centers not being sustainable in the capitalistic medical industrial complex, that it can be very difficult to provide community birth midwifery care as we are supposed to, and be able to continue to live sustainably as well and not be burnt out. And so I worry about us putting doulas on a pedestal and making them the solution for everything without also acknowledging and dismantling all of the complexes in the systems that have created the issue we have before us.
Thank you both. I'll ask our next question from the registration, and I'll start asking some of the questions I see in the chat for the sake of time. But the next question is, where do you see the biggest gap in actualizing birthing justice? Where do you see the biggest gaps? How can healthcare professionals who aren't birth workers help support birth justice?
Do you want me to take that, or you take it?
I'll answer the part of what can folks do that aren't in birth work. Again, earlier I discussed how I got involved in the work that my county's public health department is doing. So again, just locally seeing what is being done. You know, I had begun to learn all of the issues and whatnot, and then I was just surprised to see, like, I came to the task force meeting like, you know, are we going to talk about midwives? We're going to talk about this. And then they were doing all that already. So just being aware and getting involved. And then on this question, I had also wanted to talk about, so earlier this year, St. Peter's Health Partners in Troy, New York, they'd announced plans to close their county's only remaining maternity unit, and that was set to close in June. It was met with pushback from community members, and then later our Attorney General in New York, Letitia James, got involved. So there was concerns that you know, birthing people were going to have to travel even further distances to receive care. And then fast forward to the latest on this event, where the center will now be receiving funding from the state budget to remain open for the next 5 years.
Yeah, I mean, the best I can give, because I work with this question in my head all the time about how to support and ask for more in terms of birth justice. But a lot of the times I find that birth justice is being led mainly by women because, you know, we're the ones being impacted the most. But I think it's an everyone issue, especially as, you know, climate change starts happening and well, it's happening now, but all of these natural disasters happening one after another, all of the concerns and healthcare costs and birthing people and people not wanting to get pregnant because they're afraid that they won't be able to have an abortion or have a safe pregnancy where they don't die. All of these things impact you, right? Because we all live in a connected world and we're all connected together, and our ecosystem can only survive and do well if we're all thriving and surviving. And so I think that if you can join a local birth justice grass movements organization or understand the policies in your state or your town regarding abortion access, or voting for those things, talking to family members about birth justice and Black maternal health crisis and all of that, it's important to get that conversation flowing, because a lot of people don't know about what's happening, or they know a little bit but they don't know what they can do. And it could be just you talking to them and saying, hey, let's do this together, or let's fight for this together, let's go to this meeting tonight to learn more, whatever it may be. That can help a little step at a time.
And I just wanted to add to this question as well. So just speaking from a medical student perspective, I feel like the biggest gap in actualizing birth justice is just like the support. Sometimes when you're passionate about something, it could be hard to find like the necessary like routes that you need to go to in order to bring things to fruition. Also, sometimes when you are really, really passionate about things, you can actually find a really good support like the SMA. I was like grateful to find you guys. But on a smaller scale, it's not always like that. And sometimes it takes a little bit longer to kind of chip away at what you really believe in over time to actually see anything come to light. So I would say any healthcare professional that you're around, I think if you just continue to like advocate or just continue to speak about what you're passionate about, you'll end up getting like the group necessary that you need in order to continue to actually bring your ideas to life.
Thank you all. All right, I'm going to move us into, we have a couple questions in the chat. First from Hannah Grace Ramsey. Is this training public was the question, and also can you repeat, I think this is Anna Sophia, what you say about the warning statement pertaining to it not being a time for comforting white tears? I love that, and can think about a discussion in one of my classes where that would have been very helpful.
You cut out just a little bit. On which question are we looking at?
Oh, my apologies for
that's okay.
Hannah Grace Ramsey. I'll post it in the chat again.
I'm looking for that one.
That question was actually, she sent me a message personally, so I got the information. I'm not sure if other people want to also hear it again, but thank you.
I did answer. And if people want to hear it, I can reply all to everyone in the group.
Thank you. All right, I see the next question from Daryl Taylor. This question may be beyond the scope of this group, but I'm hoping that one of you may be able to point me to some literature resources on this. Given the increasing impacts of climate change and heat stress on underserved women, particularly regions where access to healthcare may be limited, how can midwives leverage their role as community-based healthcare providers to mitigate these risks? Specifically, what strategies can midwives employ to address the immediate health risk of heat stress during pregnancy and postpartum periods? And how can they advocate for broader climate resilient healthcare systems that support these vulnerable populations? And
so I sent two resources to that person in a private message as well. But midwives internationally are taking a really big lead on climate change and being the proponents of going to, midwives are the ones who provide care in the rest of the world, in terms of they're the first line for perinatal care, and then an OBGYN, if there is one in the community, is called in for emergencies and other things like that. In this country it functions in the very opposite way because of the things that were outlined and how all forms of midwifery have been either slowly chipped away or deliberately chipped away or taken away completely with direct policies. And so the International Confederation of Midwives, which is this international group that works out of The Hague in Netherlands and sort of tries to have various midwifery ICM chapters in different countries in the global South and East and everywhere, are proposing that midwives as care providers become key players in designing resilient health systems capable of withstanding the worst impacts of a warming world, and delivering sustainable, environmentally healthy services. And so there is a toolkit that I just shared about what we can do as midwives, or where you can go in that website and find more information about that, and also a study on midwives as climate change defenders and bringing healthcare to folks.
All right, Tajah, Todd, anything to add before I go to the next question? All right, our next question is from Cindy, who said, awesome job on your presentations. I wanted to understand if there exists a protocol to assess maternal health prior to scheduled labor deliveries. How late the pregnancy? Is there a difference in pre-labor planning for expectant mothers with comorbidities versus the ones with none?
I'm looking for that too, so I can read it and make sure I'm understanding the question. Okay, I think I understand what you're asking, but correct me if I'm wrong. So when you, well, first, if you have the privilege to access a primary care physician or family medicine person or a nurse practitioner that can help you prepare for a pregnancy before you conceive, then kudos to you for winning the best healthcare system in the United States of America. But most people, unless they are lesbian or gay or having infertility issues, most pregnancies, about half, happen to be accidental pregnancies, as we call them, or hey, here's a baby. And so most people don't know that they're pregnant until about the end of the first trimester, which is why a lot of these 6-week abortion bans are insane to think about, because most people don't know that they're pregnant by that time. And so we as midwives will sit with you when you do come in for your first prenatal visit. That's why that first prenatal visit is super important to be done early enough, and why we need to increase midwifery access and also just obstetrical care access as a whole in this country, because a lot of people are entering prenatal care really late because they can't find a provider. And so that initial visit is super important for us to go through your family history, your life, your lifestyle, what's going on, how's your health, and all of that, to sort of assess if you fit into quote unquote low risk pregnancy or quote unquote high risk. And then there's the moderate risk. There's levels to the risk. And from there, we can help identify whether midwifery is the best choice for you, or whether you need an obstetrician or a maternal fetal medicine provider, because your pregnancy is an elevated high risk, and you need more tertiary care and more testing than a midwife can provide for you. And so that starts pretty early. And then as pregnancy goes, things can happen and you can risk into another risk level. And for most places in the Northeast, we do collaborative midwifery management. And where I used to work prior to being an academic midwife, we were about 30 minutes from Boston, and maternal fetal medicine was over there. So us as midwives in that practice essentially consulted with OBGYNs, but we kept all of our patients, even if they were high risk, but they went with chronic hypertension to the OBGYN to make sure the medications were correct. With insulin dependent gestational diabetes, they were managed for their gestational diabetes with the physician, but kept coming to us for midwifery care, which again is a different philosophy, different way of providing prenatal care. And different states, again, have different laws for different midwives, and scope of practices and comfortability level of the midwife can also come into play. But that sort of, I hate calling pregnancy risky or anything like that, but that sort of risk assessment or evaluation is ongoing. And so we're trained in normal and then able to detect abnormal. And so that's when we tap on our collaborative partners. I hope that answered that question.
Thank you, Anna
And
Sophia. Oh, go ahead.
sorry, there was a last part, the pre-labor planning. So even if you're someone with a high risk, like let's say, what's a high risk condition that would take a lot, like if you had a mono-die twin pregnancy gestation, there are some MFM, maternal fetal medicine places that employ midwives to sort of give that midwifery care and plan for if your first presenting fetus baby is head down, to then have like a vaginal breech extraction and have the midwife be part of your care throughout that. But that is very rare. I mostly see it in the Northeast and California and some places in Oregon and Washington where midwifery is in abundance. But that is pretty rare. And in terms of home birth, they do have home birth midwives have their scope of practice and are trained in being able to say, okay, home birth may not be for you. We might need to tap in a doctor, or we at least need to consult. So again, midwives very well trained in setting you up for and expectations of what labor may look like for you and working with you to get what you would like.
Thank you, Anna Sophia. It is 9:01, 6:01 if you're on the West Coast. So I'm going to move us into closing. Thank you to our speakers, Tajah, Anna Sophia, Tajah. Give them a warm round of applause. So show them some love for all the wisdom and knowledge they've dropped in this session. Thank you all for attending and the great questions and comments. For those that we didn't get to, I think maybe we can work offline to share those responses. And then I wanted to highlight the next webinar for the Student Assembly, which is titled Saving Primary Care in the United States, an Interdisciplinary Dialogue. This is happening November 12th, same time, 8 to 9 p.m. Eastern Standard Time. That's the thing, yeah, Eastern Standard Time. And I'll drop the link to the Student Assembly page where you can learn more about them and their events for future engagement. Rob, if there's nothing else, Andrea, if there's nothing else, I think we can officially close.